So again, welcome. We are affectionately call this our 3D or our Delaware Data Discourse. This is behavioral health data highlights from the 2023 Delaware Epidemiological Outcomes Profile. We are, again, from the Center for Drug and Health Studies at the University of Delaware. And we are privileged to facilitate the SEOW on behalf of and with support from the Delaware Department for Health and Social Services Division of Substance Abuse and Mental Health, or DSAM, through a SAMHSA award. The SEOW is something that happens or is a work group that occurs in most states. And the 4 goals of the SEOW are to identify, analyze, and share data, create data products, train communities and other stakeholders in understanding and using data, as well as build state and local level monitoring systems. You'll see there on the left-hand side a screen grab from our website. We will make sure that the website is in the chat for you so you could check that out. We have a number of different data products on our website, as well as the Epi Report. All right, so you'll hear us call the Epi Report because epidemiological is a long word, right? So the Delaware Epidemiological Profile, or Epi Report, is an annual compilation of data highlighting substance use, mental health, risk and protective factors, and special topics. It's a resource that folks can use for needs assessments, grant applications, evaluation planning, presentations, public awareness, and media outreach. We pull data rather from dozens of different resources. So it's primarily secondary data analysis included in the report. On the left-hand side, you'll see a number of different instruments that we pull from. That may be something like the PRAMs. In-house, the center also facilitates, administers some of the school surveys. That data is in there. So there are a number of different data sources with obviously different years that the data is available, most recent data. So we try to pull together those sources in a way that's comprehensive and cohesive. We moved to a more streamlined format. We heard from our funder as well as our stakeholder. Traditionally, the Epi report's about 300 pages. Shout out to those folks who read all 300 pages. But we have this year attempted, and a lot of support and encouragement goes out to Sharon and Rachel Writing, another colleague, who managed to take all of that data and information and synthesize it into a way that is digestible, but also tells the story around the data as well. So there are a number of different chapters or modules: tobacco and e-cigarettes, alcohol, marijuana, opioids, other illegal drugs, maternal and behavioral health, gambling, mental health and wellness, persons with disabilities, ACEs and other trauma, gender and sexuality, and protective factors. And so when you go to our website, you'll actually see that these are pull-out chapters that have already, there are links there for you. So if you're writing an application for a grant and you really want to focus in on opioids, or you really want to focus in on mental health and wellness, you can go right to that chapter. I do encourage you, if you want to read all 300 pages, well, it's not 300 pages anymore. You certainly can. It's available for you to read the whole thing, but we do try to make it as accessible as possible by having the chapters available as well as the infographics. So we have, again, a number of infographics that align with the chapters. We encourage you to check those out. We will be providing a executive summary and Epi slides, which have which correlate, with the chapters, and just pull out the data as well. So what's new? As I mentioned, we did try to successfully streamline the modular format for each topic. We have a companion guide, which includes background and supplemental materials, notes. It's really important. One of our goals, and it's important for me as a facilitator of the SEOW, that the data is as user-friendly as possible, right? So how do we understand the data? How do we understand it better? And so that companion guide is designed to do that. We have a newly organized tobacco and vaping chapter, and any recent legislation updates are included there as well. All right. Some notes on data reporting and interpretation. This is included in our Epi report. I'm gonna zoom through it real quick here. because it's not super relevant today, but it doesn't provide some important context. Typically, the data that we report, we round to the nearest whole number. So if you go to the original source, if they've done something different, there may be some differences there. How we take care of missing observations is slightly different than some other data sets. Some people will incorporate them into their numbers. Some people will analyze the data, not including the missing observations. We have taken the policy in-house not to report data where the cell is less than 30. So if only 17 people responded or whatnot, we don't necessarily report that data out. Or you'll see as Sharon's working through the slides with the data, they'll, it may say something for 5th and 8th and it's missing for 11th, or it's not reported for 11th. It might just be because that number is just too small. We have a note in here about statistical significance and so on. As I stated, if the raw number is less than 30, we don't report that out. If folks really, really want that data, or there's a burning need for that data, we could maybe point them in the direction in order to do that. As I stated before, we round to the nearest whole percent. So occasionally, if you add it all up, it may add up to 101%, because we're rounding to the whole number. Again, missing observations. So for the Delaware School Survey data, shout out to our colleagues at Center for Drug and Health Studies who administer the Delaware School Survey, as well as the Youth Risk Behavior Survey and the Youth Tobacco Survey. So we do not in-house, missing observations are not calculated into the total percentage. So it may be that question number 20, if not all 3,000 students answer that question, the end total might be 2,500, for example. The next question, 2,750, may have answered, and so the end total is a little bit different. And I know that's kind of difficult to conceptualize without seeing it, but you may see that the number of people that answered each question varies because people skip questions for a variety of different reasons. They don't understand the question, they didn't see the question, survey fatigue, so on and so forth. And so that's just something for you to note as well. And then the other thing that we want to make known is that there may be some slight differences because we are doing secondary data analysis or secondary data reporting. There may be some slight differences between what we put in the Epi report versus if you go to that original data source like Burfus, for example. This is due, again, usually to differences in rounding or handling missing observations. So how the CDC does it or Westat does it for Youth Risk Behavior Survey versus how we do it in-house may be slightly different. And then everything, unless otherwise noted, is statistically significant at p-value less than 5. In other words, what that means is that this suggests that in 95% of cases, the correlation between relevant variables is not due to chance. So what that means is less than 5% of the time, this is just a random occurrence, or that the connection between two pieces of information is by chance. This is not hugely relevant to most folks other than to know that your data is solid, that it was done in a statistically significant way, and that you can put some trust in any connections that's displayed by the data. And weighted data. So some folks you'll hear again differently. This is compensating for non-responses or missing data. How we do that is slightly different. Everybody uses different weighting techniques or methods, and that may vary, so you may see some differences. If we've weighted the data, that'll be in the notes. A good example of that is there on the right-hand side. And I think everywhere we go, everything we do, we have to go, and then COVID, or because of COVID. So anytime you see our Epi report or any data that we put out, we do want to remind you that trends are slightly challenging, and that the pandemic has not only influenced people's response to the data, but it may have also impacted data collection itself. And so that's we always want to give that caveat. Delaware School Survey, you'll hear us mention that a lot. That is for the first time, an electronic data collection method was offered as an option for the DSS in 2020 due to COVID. And then a portion of that was suspended. Once it resumed, schools could elect either paper and pencil or the online questionnaire, which is super exciting. Due to the data gap in 2020, as well as the changes in methodology, results of the 2022 DSS, which is what we put in the Epi report this year, should be compared with caution. So that just means, if you see something in 2022 and you go back and look at what it was in 2018, just the differences there could be because of administration type, or it could be because of COVID, or it could be some other underlying issue. So if you have concerns about that or questions about that, we're happy to dig into that with you. The sample size or responses numbers are there on the bottom for you. The Delaware Youth Risk Behavior Survey, which is facilitated in partnership with the the Division of Public Health, is administered in odd number of years. So 2023 was the last one. It's not in the Epi report, but once that data is finalized, we can start having discussions that include that data as well. Administered at the middle school and high school level. And then we're rounding the bend, folks. We're going to get to the good stuff, but it's always important to us here that we talk about word choice, right? So language frames how people think collectively about behavioral health and is continuously evolving rather. I know it's really important for me and as well as the team that we use words that are accurate. We get away from using words like significant when we don't really mean that. Respectful, free of stigma, strength-based, trauma-informed, and inclusive and culturally sensitive. However, much of the data and information are drawn from those other sources. And so we try to preserve accuracy by sharing it exactly as it came from that data source. However, if we feel the language is not, person first, strength-based, so on and so forth, then we'll change it, but we'll make a note that, hey, this is how this language was originally used. And we see that sometimes in the use of the word abuse. So substance abuse is still used a lot, and we get away from using that language quite a bit where we can and where we have the latitude to do that. If not, we will make a note that that's how that came from that original data source. All right, Sharon's gonna get us rocking and rolling on some really interesting data. Thanks for bearing with us through that part of it. Sharon, let me know when you need me to move slides, okay?
Thanks, MJ. And good morning, everyone. Happy New Year. And I'm delighted to see so many folks in the room interested in the data. I just want to say before we get started that this is what I would consider, an introductory to the data for the current issue of the Epi. This by no means are we going to be able to cover everything that's included in that, because there are over, even though it's been streamlined, there are over 200 figures still included throughout all the modules, with representing hundreds of data points. So what today is intended to do is to not only share some of the highlights that jumped out at us in terms of the data, but also to provide you with a sense of the various data sources that we look at and monitor in creating the Epi report. And we hope that this is something that you'll use as a launching pad for diving more deeply into the data and taking a look at it as you need to, at your leisure, whatever, because we couldn't possibly cover the waterfront in one session today. I will ask that, because I'm gonna go through these fairly quickly. And we're going to take a little bit of information from each of the modules that we covered. And if you have questions, I think it would be best to put them in the chat, and we can save those for discussion at various points. So I'll ask MJ to advance the slide. So the first thing I wanted to do is just give you a quick snapshot of the substance use rates for 8th and 11th graders that we've got in this year's report. These data are coming from the Delaware School Survey that you've just heard about. This is the 2022, which was the most recently available data at the time that we compiled the report. And we'll start off with taking a look at the 8th grade. You can see here that Alcohol remains the most commonly used substance among 8th graders. This is past year use. About 1 in 7 students reported they had used alcohol during the past year. And about half as many reported that they had used marijuana. You can see that vaping down on the end of the chart is something that approximately 1 in 10 kids has reported that they have attempted use of during the past year. So we know that that's something we've gotten our eye on, keeping our eye on that as an issue, especially among younger students. Next slide. So we have a similar slide overview here for the 11th graders. And again, you see that alcohol use was the most frequently reported for past year, with 1 in 3 students reporting that they had used alcohol at least once during the past year. And you see that more than 1 in 5 reported that they had used marijuana during the past year. And again, that vaping at 16%, approximately 1 in 6 or 7 students has reported that they vaped during the past year. You can also see that the use of tobacco is relatively low at 3%, still higher than what we would like to see, unfortunately. But if you'll go to the next slide, we'll take a look at the issue of tobacco, which is one of the modules included in the report. Now, we know that the rates of tobacco use have declined consistently over the past several decades for all age groups, but there's still significant health consequences associated with it in Delaware. The CDC estimates approximately 1,400 adults in Delaware die each year related to smoking-related illnesses. So one of the data sources that we draw from is the BRFIS, or the Behavioral Risk Factor Surveillance System, which is administered by the Division of Public Health on behalf of the CDC. The BRFIS allows us to take a look at certain characteristics. One of those is age group. So this is a slide that illustrates the BRFIS data according to age for the state of Delaware in 2021. The overall rate was 13.4% for tobacco use, current tobacco use, which is considered past month use. And you can see that in general, overall, current smoking declines with age, but with the exception of the 35 to 44-year age group. Next slide. So what I've got in this slide is a compilation of Delaware school survey data on cigarette use by grade. So we have 5th, 8th, and 11th graders. And on the left side of the chart, you can see we've looked at lifetime, past year, and past month rates of use. Now you can see that in lifetime, we were able to include 5th, 8th, and 11th grade data because there was enough to report. When the rates are very low, it's hard for us to report out on some of the grades, particularly the younger grades, because there may not be enough students reporting use, which is a good thing. But you can see that we have relatively low rates of cigarette use for all 3 of those time periods. On the right-hand side, up top, we have a look at the perceived, what the students perceive as the risk of smoking. 1 or more packs of cigarette daily. So on the top, we've got the 5th grade data, and you can see that approximately half of students think that there is a lot of risk associated with that. That drops as you look at the charts on the bottom of the slide. The 8th graders were less likely to see great risk, and 11th graders actually saw a little bit more risk, which I think might be part of the maturing process. It might be because 8th graders are more likely to smoke than do other kinds of things. I don't really know, but one thing we like to keep our eye on is the perception of risk of harm, because that often corresponds to use of a particular substance. Okay, we can go to the next slide. So now we're talking about electronic cigarettes or vaping. Again, we have some BRFIS data here, and we've looked at the overall rate of vaping among adults at 6.1%. It was most prevalent, not surprisingly, among the 18 to 24, and then dropping down to the 25 and 34. It generally, obviously, it drops down as we get older. And you can see that on the chart, there is no data for the 45 to 54-year-old group. And that's not because that no one uses, it's just because those rates were too low for the BRFIS to include that particular age group. If we'll go to the next slide, we can take a look at, this is youth risk behavior survey data, which we also talked about in the introduction. The youth risk behavior survey we've administered to middle school students as well as high school students. They were able to break down the data according to gender as well as grade and give us a total for overall. So on the left, we have the middle school data, and approximately 4% of students report that they are currently using vaping products. On the right-hand side, we are seeing that approximately 18% are using vape products regularly. You can see that there's a pretty big discrepancy there among male and female, 13% of males and 23% of females. And you can also see that the rate of use has increased over grade level, I should say. Next slide. So obviously one of the substances we're most interested in tracking is alcohol use. We look at a number of different sources for both adult and youth rates of use. One of the surveys that we incorporate a lot of data from is the National Survey on Drug Use and Health. And this is administered annually. And we are able to look at data for participants age 12 and older. And then we're able to break those down into certain age groups, 12 to 17, 18 to 25, and 26 or older, but we also pull out the 12 to 20. This chart shows monthly alcohol use, past month alcohol use, past month binge drinking, and the perceived risk, again, of drinking 5 or more drinks once or twice a week. Alcohol remains the most commonly reported substance by youth and adults. Approximately half of individuals age 12 and older report past month drinking, with the highest rates among those 18 to 25, and more than 1 in 5 reporting binge drinking in the past month. And at the same time, perceptions of risk are relatively low for frequent use, under 50% across the board. Next slide. This is another example. I wanted to show an example of some other kinds of things that the BRFIS allows you to sort the data on. And this is educational attainment and current or past month alcohol use. So if you take a look at this chart, in general, adults with higher levels of education report higher rates of current use. In 2021, approximately 2 out of 3 college graduates in Delaware reported having at least 1 alcoholic drink within the past month, which was nearly twice the rate of adults with less than a high school diploma. However, if you look at the chart on the right, this pattern did not emerge when we were looking at rates of binge drinking. So there's no discernible distinction there. Overall, adults, again, similar to what we saw in the NSDA, 53.9% of respondents reported past month drinking, and a binge rate of 12.9% as well. Next slide. So obviously, we take a good look at marijuana use and perceptions of great risk. I know that this is something we're going to want to look at a great deal in terms of the recent legalization of marijuana in the state. But this would have
Hey,
been—
Sharon, I'm
Yeah.
sorry. I may have moved one too many slides. This is high school students who currently drink and YRBS.
Oh, I see. I'm sorry. Okay, thank you. So again, this is YRBS data from 2021. We have high school students. We're taking a look at current alcohol use, which is again past month use, and current binge drinking as well. Overall, 1 in 5 high school students report current drinking, and That's 10% among the ninth graders, rising to 37% among the 12th graders. And overall, 16% of middle school students drank. I'm sorry, this is a note from another slide, but at the same time, 16% of middle school students reported that they had ever drunk alcohol on that same survey. And again, we're seeing some differences according to gender here for both the current drinking and the binge drinking. 15% of males reporting compared to 26% of females, 6% of males reporting binge drinking compared to 11% of females, which is a little unusual. Next, now we'll go to the marijuana slide, MJ. Thanks. And I know that I'm going very quickly through a lot of these data points, just to sort of give an overview of everything. So marijuana use, this is data from the NSDA again from 2021. Past year marijuana use was approximately 1 in 5 people. Past month use was approximately 15%. You can see that the age group of 18 to 25 once again has the highest rates. And we can see very low rates of great risk of smoking marijuana once a month being reported across all age groups. Next slide. So this is marijuana use among 5th, 8th, and 11th graders, according to the 2022 DSS. And you can see that in general, obviously the rates are much higher for the 11th graders. In the DSS, we are able to sort the data on not only boy, girl, but also students who report non-binary as their gender. And we took a look at some of these just to give you an example of, another way that you can look at the data when we have various indicators. So we don't, in the top, we don't ask this of the 5th graders. So we don't have the non-binary reporting rates on the 5th graders. But we do like to, again, look at that rate of perception of risk. And you can see that there are relatively low rates of perception of risk, even at the 5th grade level. Very low rates, 23% overall for 5th graders thinking that trying marijuana once or twice is perceived as great risk. And then it does go up to 43% on average for smoking marijuana regularly or weekly. Those rates of perception of risk go down for the 8th grade and go down again for the 11th graders. Okay, next slide. So this is a chart that's drawn from the data from the Delaware Prescription Monitoring Program. And this has to do with prescriptions that have been made since, I guess we go back to 2012 on this. And there has been a decrease of all types of prescriptions being filled during the course of this past decade. One of the things that I wanted to point out is that we also can look at the rate of prescriptions. Let me get this wording right. It's the rate of prescriptions being filled for both an opioid and a benzodiazepine in the same month. We know that this is a great concern. This has dropped from 35 per 1,000 in 2012 down to 19 per 1,000 in 2021. So that is a very good indicator. It's still too high, but it's good progress. And let's take a look at other illegal drugs. So the NSDA does look at other illegal drugs, and you can see that, what is included in that calculation on the note there. Things like cocaine, heroin, hallucinogens, inhalants, methamphetamines. They look at it both with and without marijuana. So you can see that the rate drops significantly when you pull marijuana out to 3.54%. And again, we see the same pattern that emerges throughout the NISDA data, which is the 18 to 25-year-old group is the group that is using most, at 6.45% for the illicit drug use other than marijuana, and 30.14% for illicit drug use, including marijuana. Next slide. So this is just an overview from the Delaware School Survey of other illegal drug use by 5th, 8th, and 11th graders. And you can see that the rates are pretty low across the board for synthetic marijuana and over-the-counter drug misuse. We see something a little weird in the other illegal drug use, in that the lifetime use, actually the rates of all by 5th graders are higher than the rates of the 8th and 11th graders. We attribute this to the question about inhalants. What we have been told is that, some of the feedback that we've had from the administrators of the surveys, that kids seem to think that if they just smelled their markers or something like that, that includes the use of an inhalant, which might be why those numbers are inflated, but it is something to consider. And we'll want to keep an eye on that, as we like to look at weird data pops like that. So if you'll move on to the next slide, we're going to take a look at the gambling. So this is data from the 2021 YRBS again, which among high school students, 40% report gambling at some point during the past year. Males were more likely to report than females, and these are similar to the findings, which aren't included here, of what we saw in the 2022 Delaware School Survey. Now, on the right, what we like to do when we get to certain characteristics, we also like to take a look at those in relationship to how substances are used, the rates of substance use, the rates of mental health indicators. And you can see, as you look on the graph on the right, that students who reported gambling were also more likely to report past month alcohol use, past month marijuana use, and past month vaping. So that's why we like to take a look at gambling as well as a behavior. It is often associated in the literature with higher rates of substance use, and that seems to be the case when we look at our own data. Next slide. So one of the newer modules that we've included in the recent years is maternal and child behavioral health. And this year we've included a number of indicators from the Pregnancy Risk Assessment Monitoring System, or the PRAMS. The most recent data that we had was for 2020, and we were able to take a look at substance use, some select substance use indicators that are included, including cigarette smoking, e-cigarettes, hookah, and heavy drinking. The data is, the data on the middle column that says 2020 is Delaware data. The overall pool includes all of the states that participate in this survey. And you can see that we do have a slightly higher rate of cigarette smoking than the national, where the overall sample, I should say, for both 3 months before pregnancy and 3 months during pregnancy, as well as postpartum. We do see that during pregnancy, the rate dropped from the pre-pregnancy rate of 18.5 to 9.1%. When we look at e-cigarette use, it's comparable to what we see overall in the overall sample. It was 5%, dropping down to 1.4% during the last trimester of pregnancy. Hookah rate of 3.6% in the past 2 years. That doesn't break it out by pre and post pregnancy. And heavy drinking during the last 3 months before pregnancy, which is defined as 8 or more drinks a week, was 2.7% prior to, in 3 months prior to pregnancy. So we'll take a look at the next slide, which has indicators of mental health, as well as intimate partner violence, some of the other questions that are on this survey. And again, we see fairly comparable rates of depression reported for both the Delaware sample as well as the overall. 16.9% reported feelings of depression prior to pregnancy, and it was about the same, 15.9% during the pregnancy. We do see that there is a self-reported rate of 10% of postpartum depression. So that is definitely something that we want to monitor, of course. And we also see that there are a number of women, 4.3%, who reported that they experienced intimate partner violence by a partner, current partner, and ex-partner in the year before pregnancy, and 2.7% during pregnancy. Those are slightly higher than the national rates, but something, again, to be considering as we consider the health of mother and child. All right, let's move on to the next chapter, or the next.
Sharon, I actually want to jump in here. We created a data product for this in addition to the chapter, because this is such a priority population, not only in Delaware, but for SAMHSA as well. And there's opportunities here. Whenever I think about our data, to get on my soapbox for a minute, the data that we put out is looking for the opportunities for action. And definitely maternal health is an opportunity for action, not only for women as women for themselves, right, but as caregivers for the next generation, and so on and so forth. And I think there's opportunities there. That's why PRAMS does look at before pregnancy, because there's a lot of opportunities before people become pregnant to intervene and promote health and wellness. And so it's equally important to look at insurance rates is another one that PRAMS offers. Who has insurance before they get pregnant, who has insurance while they're pregnant, and who has insurance after they're pregnant, because as Sharon pointed out, that 10% postpartum depressive symptoms is not only important for women, but families and communities to address as well. And so I know that DSAM as well as SAMHSA are taking a look at this data, and there are, again, so many opportunities for us to lean in and support women during this period and in this arena of behavioral health.
Yes, I agree with everything you just said. I mean, and I would just like to reiterate, if you've ever, not only would we encourage you to take a look at the full Epi modules and things of that nature. I believe we just popped into the chat the link for the infographic that MJ was referencing. But also, if you look at, you can look at these surveys themselves and see the breadth of the questions that are asked on the PRAMS, on the NSDA. I'm gonna, in the next slide, I'm looking at a table that we created of indicators from NSDA on mental health, various aspects of mental health. And this is just, a small part of what you can find in this data set. So I'll just kind of lean into that at this point. And we do take a lot of indicators on mental health and wellness, because we know there is such a significant crossover between that and substance use. So what we've got here is just a handful of the indicators that NSDA reports out, from any mental illness to serious mental illness to major depressive episodes, serious thoughts of suicide, making suicide plans, and then receiving mental health services by age group. And, you can see that in Delaware, the rates for 2021 were approximately 1 in 5 people reporting any mental illness, and 4.3% reporting serious mental illness. And approximately 8% of Delaware estimated at major depressive episode. 3.91 serious thoughts of suicide. These are very concerning, obviously. And then, we do have approximately 18% receiving mental health services. Once again, you can see that age group of 18 to 25, the numbers are elevated so much more than the total group. So obviously that's a very critical time. That's a tough time, as people transitioning into adulthood. And, that's an area that's, I think, more challenging for us to reach in many ways because they're no longer people in school. So we have difficulty even tracking sometimes the data on this group, but this is a really important source of information. Um, and and I would just encourage you, go ahead and take a look at that data from the NISDA. So we'll take a look at the next slide, which hones in on um, this is high school students from the YRBS. And again, remember that we do have middle school data reported as well. But in high school, on the left-hand side, I've just taken two of the indicators here, which is those students who report feeling sad or hopeless almost every day for two or more weeks in a row. It's kind of a tough definition, but that's how the YRBS defines it. And then on the right, we have students who attempted suicide. So on the YRBS, there are other things such as, seriously thought of suicide, made a plan for suicide. So there's a number of different indicators here as well. And you can see that more than 1 in 3, almost 4 in 10 of our high school students are reporting that they felt sad or hopeless for a significant period of time. And I think very alarmingly, we have 9%, almost 1 in 10 students who said they attempted suicide in the 12 months before the survey. So again, these are not good numbers. And we just, we know that the kids are suffering, and, this is helpful information to track. So if we go to the next slide.
And I also want to remind folks, as Sharon pointed out, this is just a highlight. We do also look at some data by race in the Epi report, and as well as whether or not young folks are identifying as LGBTQ. So this is just a conversation starter. We definitely encourage you to look into that. If we are not splicing the data in a way that's helpful to you, please let us know and we can see if it's possible. That's the first thing. And if we're not already doing it, we always welcome that feedback to look at the data in a different way.
And I see Allison has popped into the chat interesting findings regarding the male and female difference. And that is very true, because if you look at the data, we've got 50% of males reporting on the left-hand side of the chart that they have, thoughts of, serious symptoms of depression or sad and hopeless feelings, compared to 23% of females, which is a little unusual. But then when we look at the suicide attempts, 13% of females are reporting a past year attempt compared to 4% of males. So that's a very interesting finding.
I also think, and not to geek out and nerd out here for a minute, but what's interesting is that this is such a nuanced topic. I know in the work that's been done in the space around young African American males, we tend to think of suicide as this thinking about it, attempting it, and doing it, and how that manifests and what that looks like in different groups is very different. Some young folks report not, or people in general, but young folks in particular, do not report seriously consideration and going right to attempts. So this is a topic that we've kind of distilled it down to a slide here and a chapter, but it's super important to continue to have really broad, comprehensive, nuanced conversation about this topic.
Thank you. And we'll take a look at the next slide. So we do look at different populations that may be at disproportionate risk for experiencing risk behaviors. And one of those groups that we've looked at in the past several years is persons with disability. So what we have here is a slide relating to the 8th grade data from the Delaware School Survey. Approximately, and this was a similar rate for both 8th and 11th graders, approximately 39% of 8th graders report having one or more disability. Okay. So when we look at that group, compared to students who do not report having a disability, you can see on the left, you've got indicators of substance use, and on the right, we've got indicators of mental health. And you can see just by glancing at this that there's great disproportion among all of the substance uses and among symptoms of anxiety and depression. So again, we know that certain characteristics can be associated with, different levels of risk. And if we'll look at the next slide, which deals with our chapter on trauma and ACEs. This always just shocks me when I look at it, because I think, just again, at a glance, when we look at these rates, you can see what we're looking at here. The blue are folks who report having no ACEs, and the yellow are those who have 3 or more. And you can see it's just across the board that people who experience adverse childhood adversities or other traumas are more likely to report symptoms of anxiety or depression, or using substances. The Delaware School Survey includes a number of indicators on childhood trauma. And I would just like to point out here that whenever we're looking at this issue, every instrument is including a slightly different set of what they would consider to be childhood adversities. So not every survey that we include is going to include every indicator, and the DSS doesn't include every indicator, but it does include a number of them. And among those, what we have are, 16%, 2 out of 3 students in the 11th grade reporting having at least 1 ACE. And then you get up to, 28% reporting 3 or more. That's just such a big number. So you can see where there is this interplay between things like trauma and substance use and other symptoms that are difficult. We do like to remind people that we're just talking about an association. We don't know that one thing causes another thing. We just know that there's a relationship there. But this is what we use, our quantitative data to do. It gives us places where we want to dive deeper and investigate more, and perhaps use qualitative research methods and that sort of thing to find out the whys and the hows of certain associations. So if we'll look at the next graph, the next slide, the Delaware School Survey allows us to dive into a little bit of differences in terms of gender and sexuality. So this chart just illustrates that approximately 29% of students identify as LGBTQ on the survey for 8th graders, and 26% of 11th graders identify as LGBTQ. And then in the next chart, we'll take a look at some of the associations that we find when we look at self-rated emotional health among LGBTQ students from the DSS 2022. And again, you see that there is a disparity there in the self-reported emotional health among these students compared to their sexual peers. You see that both at the 8th grade and the 11th grade. I do want to also point out that just in addition to looking at, symptoms of depression and anxiety, we also ask students to tell us, what they think their emotional health is, whether they rate it excellent, very good, good, fair, or poor. So we do try to look at not only negative indicators, but also positive indicators. And this is just one of those. We also take a look at, in the DSS, there's the Cantrell's ladders, which are indicators of well-being and so on and so forth. So that's interesting data to take a look at as well. I'm going to move to the next slide. Well, I'm going to ask MJ to move to the next slide. And we're rounding the bend here. We do like to look at protective factors because, you know, it's very important for us to be asset-based in how we approach prevention, obviously. And protective factors are, you know, they come across different domains. They might be in the domain of the family, in the domain of the school, in the domain of the community. And one of the surveys that we draw on for the Epi is the National Survey of Children's Health, which includes many questions about many aspects of children's health. They pose the questions to parents, and parents report on their child's experience. So we've taken a look at a number of these indicators here for the National Survey on Children's Health. And in this table, you can see that Delaware parents report, you know, similar rates of many indicators compared to the national pool of respondents. 4 out of 5 report that they regularly attend their child's events, that the child is engaged in school, they have at least one supportive adult outside the home to support the child as well as the family members. They were not as likely to report reading to young children often, and they were much less likely to report that the child participates in community service, which I thought was really interesting because we know that there's a requirement among high school students to, you know, participate in so many hours of community service. So I thought that was an interesting finding. And if you'll look at the next slide, one of the indicators that I really like is that the same survey, the National Survey of Children's Health, does a composite measure called the Family Resilience Composite Measure. And they look at a number of factors such as, does the child live in a home where the family demonstrates, you know, qualities of resilience during difficulties? Do they talk together about what to do? Do they work to solve problems? Do they know that they have strengths that they can draw upon? And do they stay hopeful? And I think it's very heartening that 80%, almost 80% of Delaware respondents indicate that they demonstrate those qualities all or most of the time. So I'd like to end on that hopeful note that we do feel, you know, that our parents feel that they have resilience in their homes, and that there are many protective factors in place. So again, with that, I'm gonna stop here, and we have a few minutes for questions. So is there anything in the chat, MJ, that?
Not right now, ma'am, no. I want to thank everyone for you know, hearing us and participating. Are there questions about the data or questions about the Epi report? Want to open that up to the floor? You can unmute yourself if you like, or you can add it in the chat. One thing that you know, it's really important to me and Sharon and in fact, the whole SEOW team, and you'll see this in the Epi report, is that we, even though there is risk associated, or there is a risk not associated, different groups report risk at higher rates. It's so important that we highlight the fact that being a part of a group, certain groups, doesn't necessarily mean that you are at risk. Often it's the way that group is treated. So for our LGBTQ youth, being gay, being trans does not mean that you will you are more likely to do drugs, or by being a part of that group or whatnot, or have distress, but oftentimes it's because of the way being a part of that group you're treated by other people, right? So the discrimination, the stigma, so on and so forth, can lead to higher rates of youth, or put you at higher risk of use as well as mental distress because of how groups are treated. You know, Sharon mentioned the different definitions of ACEs. You know, there's that core group of ACEs. I was really encouraged to see that in the literature and then in other spaces, racial discrimination and stigma are starting to be considered as ACEs and other childhood adversities and trauma. So that's really important. Being African American doesn't mean that I'm more likely to do a thing, but oftentimes the discrimination that I face being part of that group may put me at higher risk. So that's really super important. That's in the Epi report, but we always highlight that when we talk about this data in particular. Questions from anyone? Thoughts, comments? I do want to shout out some of our prevention partners who are here. You know, oftentimes people say, and that's why I love that we end on that protective note, is what can I do? I'm not an LCSW. I'm not a drug and alcohol counselor. What can I do? And I think that the data bears out that there is a role for everyone, whether that is a soccer coach, whether that is as a parent, whether that is as a OBGYN, there's a role for everyone in behavioral health and public health to support others. Sharon, anything else while we close it out?
Nope, just if you have questions that pop up after the fact, please don't hesitate to reach out.
All right, folks. Well, we are all done here, and our email addresses are on the screen. If you have any questions, Sharon will be sending out, Sharon or I, one of the two, will be sharing out slides, recordings, and the link for the Epi chapters. If you have any questions, please let us know. And we look forward to seeing you again.
Thank you, everyone.
Thank you.